So first up, we have a recorded presentation from Jenny Taylor. She is the LTV Well Child CNS from GOSH, and her presentation is regarding improving transition from NICU to PICU or to paediatric wards.
Hi, I'm Jenny Taylor and I'm a Well Child long-term ventilation clinical nurse specialist at Great Ormond Street Hospital for Children. I've submitted an example of best practice based on the topic of improving transition from NICU to PICU or to a paediatric ward. And the title of the area that I've chosen to talk about is Breaking Down the Barriers via a Nurse-Led Outreach Service. The team members that were involved in this case study were myself, LTV CNS, and a respiratory advanced nurse practitioner. So a bit of context and problem with the current delivery. This is a case study based on a patient who was antenatally diagnosed with CHAOS, which stands for Congenital High Airway Obstruction Syndrome. And they had a planned tracheostomy performed exit procedure during the C-section. Post-delivery, we found that they had deficient abdominal wall muscles, poor work of breathing, tracheobronchomalacia, and subsequently required ventilation via the tracheostomy. The patient had been waiting for over 4 months in an NICU for a bed at GOSH PICU. The traditional admission pathway would require a PICU admission to facilitate the switch from an ICU ventilator to a portable ventilator. This is to ensure a period of stabilisation on the new ventilator to allow for a safe transition to the respiratory HDU bed. PICU were unable to accept the patient unless the respiratory ward could confirm transfer after stabilisation due to the number of long-term trache-LTV and dependent NIV patients on PICU and the respiratory units. This was not practical, and coordinating bed availability between the discharge and hospital, PICU and the respiratory units proved problematic. There was one opportunity when a bed was lined up, but unfortunately there was clinical instability, so the patient was unable to be transferred. Assessment of the problem and the analysis of its causes. The team on NICU were not familiar with any portable ventilators, and it wasn't appropriate for the patient to be managed on a unit where portable ventilators were not supported. Training a whole unit of people wasn't feasible because the patient would only be on a portable ventilator for a day or two ideally before transfer to GOSH, and to train a whole unit of people it would have taken months. At this time I was just one single CNS for a very busy service. We'd approached other teams for assistance, however, due to staffing restrictions, because it was in the peak of COVID-19, they were not able to help. The NICU team had also referred to another London centre, where they had faced similar issues as the patient was not yet established on portable ventilation. So the intervention. Traditionally, when switching from an ICU to a portable ventilator, it would usually require 24 to 48 hours at least on PICU to ensure stability. It could be longer depending on patient condition, tolerance and bed availability on the accepting ward. As the patient had spent many months on NICU, they had started to grow and develop, meaning that they were able to tolerate up to 2 hours of ventilation twice per day. For this reason, the senior respiratory team at GOSH risk assessed whether a PICU bed was essential. We came to the conclusion that in this instance, an ICU bed may not be essential, and that we can make an exception under the circumstances. However, we felt that the initial switch and a short period of observation should still take place in a controlled environment, such as the NICU where the patient was. We knew that trying to coordinate 2 beds at GOSH wasn't working, so made the decision to take our senior nursing team to the patient. It's also important to mention that NICU was no longer the best place for the patient. They'd outgrown the unit massively, and it wasn't the right environment for them to continue making developmental gains. We also had discussions prior to the day with the family and let them know the plan. At first, they were a little apprehensive because they were moving directly to a HDU bed, bypassing PICU. However, when we explained the situation and explained that if we didn't think the patient was stable enough, we wouldn't be suggesting this plan, once they understood, they were fully on board with the plan. So on the day, myself and a paediatric respiratory A&P went across to the NICU in the morning, equipped with the 2 portable ventilators. The ventilator settings were pre-programmed alongside discussions with the on-call respiratory consultant at GOSH. Settings were based on a like-for-like swap of what the patient was receiving via the intensive care ventilator that they were currently on. The role of the respiratory A&P was to clinically assess the patient pre and post ventilation swap, interpret the results and communicate the findings with the consultant on call to ensure a cohesive plan was in place to maintain patient safety. We ensured that there was an up-to-date baseline blood gas and a set of observations pre-switch, which were all stable and within normal parameters. Once I'd switched the patient onto the ResMed Astral ventilators, we requested another blood gas an hour post-switch from the NICU nursing team and observed the patient over the 4 hours. The patient looked comfortable and had good synchrony with the ventilator, which was reflected in the blood gas and observations that were carried out post-switch. The patient was successfully transferred to GOSH via a HDU ambulance and the GOSH team, where they continued to be closely monitored in a HDU bed on the respiratory ward. So the strategy for change, we're looking at developing a care pathway for stable patients to be switched to portable ventilation under a nurse-led team to reduce PICU admission length and improve discharge times for children and their families. The measurement of the improvement, well, reduced time on intensive care units. We know that it's a big drive and a big issue at the moment. In this instance, it removed the need for a PICU stay. This will be auditable if we're able to apply this pathway to other patients. Lessons learned. We hope to develop individualised care pathways for different patients if safe to do so. We know that we need to be responsive to the individual's needs and are often faced with situations that we have not come across before. Sometimes this requires us to think outside the box and come up with new ideas to try and improve patient outcome and patient flow through the units so that the patient is receiving the right care in the right bed at the right time. Messages for others. A pan-London approach to care is essential and working within these groups to ensure the best patient outcomes. With the pan-London education work that is being done, this may result in patients being able to remain in local centres, which could improve patient flow and reduce the number of bed days in initiating hospitals, allowing more children to be treated appropriately in the right place in an efficient time. Thank you very much for listening.
Thank you very much, Jenny. That was a really interesting presentation on really considering the patient journey and where they should be seen, making sure that they're in the right place at the right time. Next up, we have Jane and Shelley. So Jane is a paediatric respiratory consultant at GSTT, and Shelley is one of our adult respiratory consultants also from GSTT, and they will be focusing on transition for children on long-term ventilation.
So I'm talking about transition for children on long-term ventilation, which there's a lot said about transition, and it is slightly different for this group of patients because they do have quite a lot of co-aligned treatments and therapies and teams that look after them, which will all transition at very different times. And also a lot of the patients, the vast majority of the patients, I would say, would be quite dependent on their parents and their carers, more so than say an asthmatic who's learning to adjust to adult life and taking on responsibility. But it is a big change for families. So what we're talking about with transition, so it often is a handover from children's services to adult service, which is really just a transfer, but we're trying to do a managed process to make things a bit better. So the definition that was put forward was a purposeful, planned process that addresses the child's medical, psychological and educational, vocational needs of an adolescent and young adult with chronic physical and mental conditions as they move from a child-centred to adult-orientated healthcare systems. And for families, that is a big undertaking. And the reason why we need to get this right, so the evidence has come out of lots of different studies in different areas, but in diabetes, you look at the follow-up rates in adult services 2 years later, and there's a significant drop in follow-up. There's certain specialities like children with BP shunts, where their death rate is considerably higher in the couple of years after they've transitioned. And renal transplants, a lot of transplants fail in the first few years after they transition to the adult service, a lot of which are quite unexpected. And actually, even in our own experience, we surveyed all of the patients we transitioned before and after transition, and actually ended up with a 55% attending a clinic in the adult service. So we weren't getting things right. So we did that survey a couple of years ago, or some medical students did that survey for me a couple of years ago. And there's a series of sort of publications that came out. So I think in 2006, there was the Every Child Matters, Getting Transition Right. There was a CQC report that said, look, we've got to do better at this. And eventually that led on to the NICE guidance, which is sort of the fundamental bit. So that was actually published in February 2016, which essentially said we need to have clear information. We need to talk about what's gone on in the past so that we don't redo things. The patients need to have the preference of their parental involvement considered. And for a lot of families in LTV, that'll mean, can their parents stay with them as they would have done on paediatric wards? And units need to sort of think about whether that improves their pathways or makes things very difficult. We need to hand over their emergency care plans, need to give evidence of their unplanned admissions, and also their futures and their strengths and what they want to do in the future. It's important to have a named key worker that helps with this process, and we should really be starting when they're year 9 at school, so about 13 to 14 years old, and various other digital tools and peer support, which possibly aren't as useful for a lot of our patients. And then if their patient doesn't transfer, then there should be a discussion back to their key worker about what's happened in that process after they've gone, not just sending the letter and assuming they were picked up on the other side. And around the same time, the CPOD study looked at and asked a little bit about transition as well, but actually it was over very much the same time as those guidelines came out. So I don't think people had really managed to put an awful lot of thought into how they were going to change their services before we were then looking at our ventilated patients. But it picked up very similar things that the NICE guidance had picked up as concern. So parents saying it was awful, you had to fight for everything. No one seems to know what's going on. It makes things much worse. And the perspective from the clinicians was very similar, that there is a tsunami of patients coming into adult services, and it's something we think about 2 days before their 18th birthday. And why can't all the processes, so the commission processes as well, all just hand over automatically into the adult service, and you don't just start again from scratch? So very similar to a lot of the stuff that was in the guidance, except for thinking about the community services perhaps in a different way, which I think we do need to think about and commissioners need to think about. Their key recommendations that they put in their process was that transition needed to avoid disruption, prepare for any unnecessary changes, and there needed to be effective leadership. And actually they did feel that it was better led by a clinician, but making sure that they were key who was handing over. And so there should be no gap in the provision of the LTV care. So how we've done things really at the Evelina. So we were moving towards trying to sort out. So in the past, we had a fantastic transition coordinator who was picking up the patients when they were 14, but she was a physio based within the adult LTV service. And so she'd got great experience of transitioning what was historically our large group of patients. So children with Duchenne and with other neuromuscular conditions, which she was already actually seeing within their specialist schools and was often seeing them with the neuromuscular team. But that was very bespoke to just that service. But actually, as our services developed, actually they're only a smaller part of our adolescents coming through. And we've got many more patients with obesity or Down syndrome or with cerebral palsy that were coming from a very different background that actually didn't have an awful lot of physio input. And it also got quite a unique story that they came through, that it just didn't quite work just having one physio trying to organise all of their transition. We then decided to try and fund this. And actually, I found that was absolutely the hardest bit of this, because getting managers from 2 directorates across 2 different bits of the hospital to understand that 2 consultants need to sit in one room at the same time with only one lot of activity going on was really a real sticking point for a long time of who should pay for it. Should it come from paediatric funding the adult service? Should the adults fund the paediatric service? And that just went on for ages until we could get a final agreement that peds would pay the time for the adult team to join us to make sure that we did this properly. And although the sort of managers understood we needed to do it, they also didn't really want to pay for it. And there's also working out where your patients are going. And traditionally, a lot of the adult ventilation services are different to the adult CPAP services for obstructive sleep apnea. So trying to make sure that the patients go in and then get separated up, probably into a separate clinic for different areas, whereas in paediatrics, they often just all fall under one centre. So once we'd got that sort of streamlined, we got ready to start going, and we did one clinic, and then COVID hit and it all ground to a resounding halt as our adult team got sent to Surrey and took about 4 months to return. So we're now sort of back to our, our process of what we want. So we did our one clinic with 2 consultants, 2 physios, and we've then restarted as we've moved forward now. So our aim is really to move the patients into the transition clinic from 14 years, and that the aim will be that they would move over to the adult service when they were 16. Now, there's a lot of discussion about when is that time and should it be when they're older, and a lot of the community services will carry on till 18. Some of the community peds services will actually carry on until patients are 21. But partly we chose 16 because the setup here at the Lane Fox was much better for 16-year-olds because they'd traditionally taken 16-year-olds straight off the bat, and so they were used to the services. But also my feel there was, if we had 17-year-olds that ended up getting admitted to local district generals, they would get moved to an adult intensive care, and they find it quite difficult liaising with paediatricians about how to manage something, but had absolutely no concern about speaking to the adult physicians about patients that they'd got out in district generals. But in a lot of ways, making sure we've done our handover in case the patients do get admitted locally, where there's a good setup for contacting the Lane Fox and what to do about patients they're weaning, it felt like the right time to do. So if we can then move them into the transition clinics and see them a couple of times each year so that they've met the adult team a couple of times, that is our longer term aim. And I surveyed our patients back in 2016 after the NICE guidance came out, and they said they'd like to meet the whole MDT team at least twice a year in that period up until when they're 16, so that then they can be formally referred after their 16th birthday. But we're very clear with our patients, they remain under our service until they've attended the adult clinic after transition. And I think if you move patients when they're 14 and explain very clearly from the start that they're not moving to adult services yet, it becomes less of a fear, because I've had with a few patients trying to avoid coming to the transition clinic because they think they'll get sent to adults, and feeling that if they just kind of avoid us for the year up until their 16th birthday, they'll never have to transition. A response from one of my patients recently was, well, I'll talk to my solicitor, I'm not going until she's 21. And I was like, well, she may be going to move over earlier than that. But I think one of the things we haven't sorted out yet is finalising some information sheets that we give to families so that they've had time to process that this is a process and not just a one-stop shop. But we need to be doing those clinics quite regularly to be able to get to that point. So, any questions? I've obviously got the adult team here with me to answer any of the questions about the differences between the paediatric and adult service, really.
Jane, wanted to ask you, legally, where does a patient actually stand if they decide to come in at 21 years for the transition rather than 18? Do they have a legal stance?
We've not encountered it, because usually when you actually speak to families and explain, you have to just work out what their fears are over the change. And I think it's actually relatively easy for us because we do have adult counterparts that do exactly the same job that we do when you're 15 as you will when you're 17. I think some of the more tricky discussions come from the patients that aren't yet on long-term ventilation, that initially there was a feel that they could just go back to the GP and be referred back in later on down the line. And when they've always seen a specialist respiratory physician, it's very difficult to feel that you're just going to go back to the GP's care and sit in the GP's care until a time when somebody's happy to pick you up and be referred back in. That I think we're getting better with that, and we are transitioning patients that are not yet on ventilation but are borderline or have had ventilation and it's failed, or have got quite a high oxygen requirement, so that they do have a link. It's harder to sell them to the adult team because that's not traditionally what they would have done. And it's harder for some of, the other specialities when there isn't community paediatrics for adults. And so I think they find it harder to find an appropriate place for these patients moving forward. Whereas for us, I think once we've explained the service, that it is fairly similar, then that they will transition over. I think there is clear guidance from the trust about when you can be admitted to the hospital at the Evelina. And after your 18th birthday, there has to be very specific, clear reason why you have to be admitted to the Evelina and not to an adult unit.
Thank you so much.
Thank you. We have another question in the message box. It says, once transitioned, are care packages the same?
So I think it is complicated and the care package is not the same necessarily, but if patients have, sorry about the echo, if patients have already been on ventilation at home with an established care package, and quite often the family and parents are usually involved, and I think it's slightly different, but at the moment our experience is still quite limited because we are picking up patients who've come over from PED, so they're quite used to navigating the system. But there isn't the same level of support. Sometimes if they've got the funding for the ventilators and things as it comes across, they might need a change. And I suspect what we will start to see is as they get older and the parents may or may not be able to do as much as they used to do, or other carers are coming into the picture, that it gets a bit more complicated, because obviously an adult who comes in who ends up on a tracheostomy with a ventilator is generally not looked after by family members and is rarely looked after by at home. Some are, but not many. Often they are placed in nursing homes with appropriate training of carers, some with nurses, but quite often carers who are trained up to manage these patients. So it is quite different in sort of established adults. I don't think yet, from my point of view, I've got enough feel as when patients are coming through, because obviously the ones who are coming from Evelina who have got these established care packages where the families are very, very involved, they will know a bit more how to manage the system and how to keep the package that they've got already. But eventually it will change, and I think as they leave education, as they get to age 25 and they have to move over to social care, and all the forms that need filling in, so it doesn't happen immediately, but it will happen as they stay in adult services. So at the point of transition, not so much. I think Hira, unless Hira's going to add anything to that, because he works with us, who's just going to ask a question.
No,
were you going to add something to that, Hira?
You've said what you that's true to what you've said so far. So nothing to add, I'm afraid.
So I don't know if that answers the question, but it's something that when they first come to us, not too much of an issue, but it will be an issue as they stay in adults.
Nasmin or Paul, not to put you on the spot, but do you have anything to add around care packages and following children once they transition into adults? Are there any challenges in terms of age ranges from an STP perspective as to when the children transition over in terms of care packages?
What we tend to find is that it's not a like-for-like process. So when you move over from continuing care to continuing healthcare, number one, it's not necessarily going to be the case there. They're going to meet the threshold for continuing healthcare. There's a lot of difference in the way that it's picked up. So we have a much more joined up approach in terms of including education and social care in the package. When they go over to adults, education isn't included. So sometimes that can cause a bit of fracturing across kind of picking up all of the packages of care. But apart from that, what we have been working on is a much closer relationship between between the adult continuing care nurse and the children's nurse, so they kind of have an understanding of what those assessments are going to look like. So it hopefully makes transition a little bit easier.
But just to add what Paul says, I think it's important to look into when we do the transitioning, it's a family, because a family for children, we involve the family to make all the decisions around the care packages. And at times when they move into the adults, they find that transition really difficult. And there is a gap that where we need to do a lot more work with the family during this period to ensure that they are ready to take that to give the responsibility away to that young person when they turn 18. Because sometimes they're not ready to do that. They're not ready to let go, which causes quite an upsetting time for the family as well as the young person.
Yeah, and I think it's one of the things that we've found in the local transition meetings is trying to be clear what services are available and get that transition in early. So what we don't want is to heighten the expectations of family when they do transition, having a named person who will offer them a range of services. And when it comes to the actual transition, they don't actually get anything, because that just causes a lot more problems in the long run. So yeah, kind of managing that process a lot earlier is also really helpful.
Thank you both very much, Jane and Shelley. We'll move on now we have Rebecca Daniels. It's a recorded presentation, and it's around hospital admission protocol for paid carers.
Unfortunately, Danielle Taylor isn't around today because she's actually the author of this and has put on all of our really hard work. So she's our continuing care nurse specialist for NEW. And this hospital protocol came about supporting children with continuing care. And so it's not just LTV, it is all children with continuing care for when they go into hospital. And so it's an admission protocol that supports their care package going with them alongside on admission. Now, historically, social carers used to go in, but health used to stop it. But we got to a situation where actually our children were being admitted into a specialist respiratory wards not in the local hospital, needing ITU beds, and work was done with CCG. And actually they were very pro this around putting in a system where the care package could follow the child into hospital and remain with them in hospital throughout their stay. Obviously, the question about double funding, and that was one of the first kind of things that we went through. But really, this protocol was about the agreement for setting out the roles and responsibilities and of the care agency, of the local of the hospital where they are, and the NHS staff. And also the parents as well. So, and I think one of the things I will say is this doesn't take over from parental responsibility. So, as you can see, it goes through all communication, timesheets, about them being signed off with timesheets, and this is about the parent role. So really clearly that, it is the parent's responsibility to go in until they're fully admitted. The parents need to be there if there's any issues around consent, for handover, for ward rounds, etc. Obviously, the hospital role will be to make sure that they still allocate staff to meet the acute needs, because one of the things when our children with continuing care get admitted to hospital, it's usually when they've got acute changes to their normal healthcare, and obviously the continuing healthcare package in the home manages their day-to-day, and that's usually a stable and a well child. So when if they're going into an acute setting and they're unwell, they still need to have allocated staff on the ward who would work with the care staff. The care staff would meet the day-to-day, and the hospital staff would meet the acute needs. Obviously, as community nurses, we're involved because obviously we oversee the package, although it's outsourced agency, and it's really important that the carer's role is in here as well. So what they can and can't do. So they are very much there to follow the day-to-day care of the package that they would do at home. They are not there to meet the acute needs. One of the benefits of this is that they know the child really, really well, because they work with them on a continual basis. So they know what's normal for that child and what's not normal. And that's something when you've got a child in an acute setting, especially we've seen during COVID, if a parent can't stay, they are the advocate for that child, and they really do push forward the need and what's normal and what's not. We've had some examples where we didn't have packages in and children were over medicated for seizures, and then obviously had more neurological deficit where actually those seizures were quite normal, and especially when you've got disabled children, there's no parents around with them in the hospital. So this document was pulled together, and it really is a joint agreement. We're really trying to push this forward and looking at how we can get this on a digital platform so that this is an anonymised version, and obviously it is, as you can see, joint from East London Foundation Trust and NICU Clinical Commissioning Group. So I'm just going to share my screen if that's okay, just so I can see you all as I'm going through some of the benefits and the so what it does is it obviously supports the admission, so it means that admission is much quicker, so they can go into the hospital. There's reduced anxiety because the parents know that there's somebody with the child when they can't be with them that knows them really, really well. From the child's perspective, it really reduces anxiety because the carer is familiar. So in a place where you've got no parent, if they can't stay because of other childcare commitments, you've got a carer who really knows that child, and that child has that familiar face and that interaction, so it's less frightening for them. It protects the care package because if you've got a child who goes into hospital for 1 or 2 weeks for a prolonged stay, if they're critically unwell, then the carers will normally get put back onto other packages, and there's a risk when it comes to discharge that we then don't have those carers available to work. Can reduce length of stay as well, so because you've got the carers package already in situ, if a discharge, if a discharge date is a Friday and it's a Friday evening, we've already got the care package available, so it's a fairly swift discharge home. We've had it in the past where we've been able to get children in for sleep studies a lot quicker because their regular carers can go in and be there to do their tracheostomy care or their ventilation needs overnight, so they've not needed to go onto a specific respiratory ward where you've got trained staff. And also the really key thing is the reduction of the need for specialist bed. So these children wouldn't need to go into an ITU. They wouldn't need to go into a specialist respiratory ward. They could go to the local hospital as long as you've got somebody on the ward that can meet the acute needs with the carer who can meet their day-to-day and they're familiar. What it doesn't do, as I said, is replace parental responsibility. It doesn't replace the need for an allocated nurse on the ward because these packages are not 24/7 and they don't meet the acute side of things. And obviously what we've seen with our experience of this is we've utilised this much more with local hospitals. When it comes to tertiary centres, if a child is being admitted to say Stam or Great Ormond Street, the package tends to not follow them up there, usually because it's more of a routine admission. Parents would need to be on site much more because they need their input into it. We asking carers. So that's our protocol, and it is something that really would be great to see kind of wider used. I know different CCGs have different opinions about the double funding and the questions around that, and that can be some of the blockages. And I think it's really thinking about how can we get this so that actually this is a standard that everybody, that it doesn't matter if you live in Newham or if you live in Tower Hamlets, that your package goes with you regardless of.
Sorry, I think we've got a slight technical hitch there. But thank you very much to Rebecca. The hospital protocol document is something that definitely has been identified as something that's needed within our regions, so it's a really useful and helpful piece of work. So next up we have Nasmin and Paul. Nasmin is the head of CYP commissioning and at Greenwich and Bexley, I believe, and Paul is the CYP for Lewisham, and they are part of the South London CCG, so they're going to be presenting to us some of the work that they've been doing as a joint CCG.
Thank you, Jacqueline. Evening, everyone. I just wanted to say that I'm really excited to present the work of the system change in South East London CCG, and it's around children in continuing care as part of the CYP agenda. Can we have slide 1, please? Thank you. So it's definitely time for change. As we know that following from the NHS long-term plan, and of course as CCG mergers, it provides us an opportunity to look at CYP in a much more a wider scope and bring in a bit of attention to it. As many of us know that CYP is always lowest on the agenda, but for now, for these children, particularly for these children, it's important that we focus our attention on. So the first slide is just a statement to remind ourselves why we're here, as we're aware that these children are the most vulnerable in society and likely to have the poorest outcome. And considering the investment that we're making as nationally, it amazes me that we're still yet not been able to improve their outcomes for them. So we've given them life, but I'm sure we can improve their quality of life. So this is multiple factors affect this. Of course, we know it's either the system, it's either the agenda keeps changing or making them as a priority. So we're committed in South East London to reshape our continuing care process, call it a system change, to look at the areas. Slide 2, please. So we're committed to, like I said earlier, to improve the quality. And in order for us to do that, we in South East London had a look in our own borough. So it's a merger of six CCGs, 6 boroughs now, should I say. So the merger of the 6 boroughs then allowed us to have some opportunities where we can actually really look deep into our current provisions that we're providing. What transpired that each of the boroughs, we had different models. So for some boroughs, we had NHS provider providing the assessment and providing and delivering the care. For other boroughs, they were just commissioned NHS provider to provide assessment. Some models were with adults, some were children were on their own. So the variation and the approaches were really different, were fragmented. And it's okay to have different models as long as we have a clear direction of travel in terms of where it sits in the governance, so we are all accountable for it. But what transpired in South East London, that our policies, our pathways, they were all different, which then gives a bit of gives us less of an accountability as commissioners, and also has an impact on children and their families in terms of the offer that they receive. So it becomes like a postcode lottery, like Rebecca mentioned earlier. I believe that every child should have the same provision as an individual provision in depending on their needs, but the approach should be consistent. So slide 3, please. Yeah. So we undertook, so in moving our system forward, what we did as commissioners, we brought together all the commissioners from all the boroughs and we looked at the data in detail. And what we had asked from each borough is to give us an idea in terms of what they're supporting, the care packages, in terms of the providers that they're using and the cost attached to it, and what type of care that the families, the children in their areas are receiving. What transpired that there was a variation of policies and assessments, which meant that there is there is a gap in terms of what they receive as in the provision of care. So what we looked at, the cause of it was that our system was fragmented. How we make our decisions with our local authorities were all different, and how we can improve it. So in order to improve our system, we basically looking at the areas which Paul will go through in a second. But it's more about improving the quality and improving the accountability that would then likelihood improve the outcomes for our children and young people. I strongly believe that they need to be equal in our platform in society and have the fair chances like their peers do. If we can, save lives, then I'm sure we can improve the quality of life. I'm going to hand you over to Paul, who's going to go through the details of what our direction of travel is.
Thanks, Nazmin, and thanks again, just echoing the thanks for having the opportunity to discuss what we're doing in South East London. So the thing that before the South East London merger was happening anyway, we were already organising meetings of each of the commissioners to discuss issues around continuing care. We'd recognised, as Nazmin said, there were some issues. And as a consequence of that, we've just reinforced that with having regular meetings to discuss the work that we're doing. Part of that is working on not just the commissioners, but the practitioners, because they're the people who are working with the families, and they're an important aspect in all of this. So we're getting together a continuing care nursing network to try and get them to offer peer support and allow them to discuss cases, approaches to families, differences in the way the assessments are done. And we're hoping that that's going to actually become self-sustaining. It's going to be a network which they can then rely on. As we said, we looked at the policies, the core offer and the assessments across the 6 areas. Although there is a national framework, how that's implemented, we identified was slightly different. What the different areas offered, the relationship to the local authorities meant that some of the support that we provided was very different as well. Future items that we're going to be looking at as well is a provider network. As Nazmin said, it was identified that some had in-house provision using the local health services, where a lot of us have different kind of relationships with private providers. And even though we might be using the same provider, those relationships are very, very different. So again, to help consistency, we're looking at implementing a network across South East London, possibly a single type of framework, so that we can get some consistency in the packages and the care that we have for our children and young people. And that includes a single provider contract, as we'd identified in terms of costs. With commissioners, we're always going to look at some form of money, that there are variations in what we're paying for the care. Again, this is about improving the quality of the care that we're providing. So at the moment, there's a lot of risk held with the different commissioners in the areas, and we want to try and make sure that we can suitably account for the level of quality of the services that we're providing, whether it's ensuring that carers are properly trained, that we've got a set of competencies. There's been other discussions with the South Thames Paediatric Network, for example, on the long-term ventilation and tracheostomy competencies, but we want broader competencies around not just nurses, but carers from domiciliary care, so that everybody in South East London offers the same level of practice and quality of care, as well as having a framework to assess the quality of the agencies. So it's not just about their CQC rating, but it's their management and implementation of policies which put the children at the focus of the care. Also, something we recognised was that in terms of health inequalities, sometimes it can be difficult to get that information because of the way that with the information that we have. So that's one of the things we're looking at improving as well. Can I have the next slide, please? So our strategy is to have a program management group. So this is we have the regular meetings, we have the working group, which identified areas of change. We basically have a work plan with different work streams and identified leads that will pick up on different areas. At the moment, we're having weekly to bi-weekly meetings just to keep that momentum going. But once we've got more kind of stable, then we'll probably lessen that to give people a chance to come back and identify where they've made impacts. And the overall key aim is to improve the patient pathway and experience and outcomes. Outcomes for children with continuing care can be sometimes a little bit difficult, so we're quite keen to work with our nursing partners on identifying those. A lot of the time, what we seem to provide is respite for families, or just ensuring that children that have a safe night, that their tracheostomies are in place, that there's no concerns. But we'd like to improve those outcomes and identify other areas where we can improve their wider living, as Nazmin said. Next slide, please. So what we learnt. So having clinicians working together is really important. Commissioners, yes, we hold the purse strings and we're very involved in making sure that the quality of the care is good, but having the clinicians working together is really important because clinically they have oversight of the support for the children. Having peer support has been really, really important. Sometimes it feels that we can be working in a vacuum, but having that peer support means there is somebody to talk to, something to discuss. It's a forum to discuss ideas, and that leads to kind of exciting changes. And just having that discussion gives you the opportunity to kind of look at avenues you might not have considered previously. recognises the strength in working together. Obviously, we don't want the postcode lottery. We do want consistency, and we're all working for the same thing, which is making sure that young people are at the core of the services that we're delivering. And a key element of this is parent and family engagement. We tend to usually get involved when there comes to a point of crisis. There needs to be an increase in packages, and because there's sometimes hospital discharge, it all seems to be very critical that care was put in place without necessarily having the engagement with parents and families around what is it they actually want more broadly from the package of care. How do we work with SEND and with social care to ensure that there's a more rounded support for those families when they're discharged, to ensure that their children and young people thrive. And that's it, I think. Thank you very much.
Thank you very much, Nazmin and Paul. Are there any questions for Nazmin and Paul at all? I think one of the things that really stood out to me is how you're trying to draw health, education and social care together, because we know in our region that that's one of the definite areas of challenge. Do you foresee any additional challenges with the changes into the ICSs in delivering on this plan at all? Or do you think that will help to strengthen things?
I think, yes, there are challenges. I think that's what we've recognised is that although we're one ICS, we're still dealing with 6 local authorities that have their own ways of working and relationships with the local CCGs. So although we're kind of trying to identify where we can put in place best practice and how we can work better, what we're doing is trying how we implement that locally between each of the 6 commissioners, essentially. So it's a challenge, but it's one that we're kind of taking a step at a time.
Brilliant. Thank you very much. So next we have a recorded presentation, and that's from Amy Moran, and she's from Lewisham and Greenwich, and it's regarding ageing transition for families to the DGH.
Hi there, my name's Amy and I'm here on behalf of the team at Queen Elizabeth Hospital in Woolwich to talk about our project to aid transition for our LTD patients and their families from their tertiary centre to us at the District General. And thank you for having us to talk to you today to share our experiences. This is a photo of part of the team involved in this project at Woolwich. We've got Dr. Tom Manjoka and Dr. Jessica Thomas, who are 2 of our consultants, both of whom have an interest in respiratory medicine. We also had a member of the Children's Community Nursing team on the panel, who is Rachel. We've got Hema, our children's physiotherapist, and then we have got 2 of our inpatient nurses acting as a link for the project, Ali and Nick. For those of you that don't know, Woolwich is quite a busy district general in South East London. We serve a large population of often quite sick children, and we provide high dependency care for these children as needed. Although, as for most of you, that high dependency care isn't currently funded. The need to look at our LTV practice came around for a number of reasons. We know that numbers of children on LTV is increasing, and these patients spend a large chunk of their time in their tertiary centre before being discharged home, where they may or may not be picked up by the Children's Community Nursing team, depending on their needs. And although the local paediatrician should always be involved in the discharge planning process and then in their care once they are discharged, that often doesn't happen. It often gets missed. You know, the infrastructure in the NHS is still quite fragmented and quite ageing. You get doctors moving around, you get letters copied into the address not being quite right. And so you can end up having children in your area on ventilation without you at the District General knowing anything about them. Particularly because these children have spent so long at a tertiary centre, that's where them and their families often feel safe and comfortable. So when they're unwell, they often will take their children up to the tertiary centre. But if they call an ambulance, then the ambulance might bring them to us, despite the fact that we've never really met them before and we might not have their most up-to-date care plan. We also know that there is limited capacity within the high dependency network for these children when they're unwell, and these children can often be taking up high dependency beds when well, awaiting modifications to housing, for instance, which could be facilitated at the District General. So really, we feel like there is a need to improve the service we offer the children and their families here at Woolwich, and also a need to meet and know these children when they are well, so that when they come to us unwell, we can offer them the best possible experience. This was a quote from one of our patients and their families who really wanted Safari, which is our children's inpatient ward, to be a place that knew their child as an individual, looked after their child when they were sick, and wasn't just a holding place while people were on the phone or waiting a bed at the Evelina. And I think that sums up the drive for our project. So what we set to find out was actually who are our patients and what are their needs, you know, who's involved in their care already, what are competency levels within our staff, and can we manage these children? So in order to find out who these patients are, I mean, we literally just threw down on the table all the names that we knew of, turned to our colleagues in the community children's nursing team to find out who they were delivering equipment to, who they were looking after, and to collate a big list. We needed to agree staffing ratios, and we looked at the national competency documents for that. So to make sure we could actually look after these children on the ward. We're quite fortunate in Woolwich that we've got 20 inpatient beds, 12 of which are cubicles, which does help when you're looking after children who are on ventilators of one form or another. We needed to develop a staff training package. We've got about 90 nurses and HCAs within the children's inpatient ward, A&E and paediatric assessment unit, as well as the doctors that rotate around on a fairly frequent basis. And we wanted champions from each of those disciplines. So we looked to the inpatient staff, to nurse champions to both attend the clinic, drive the education. We appointed lead consultants for the project in the same way that the POSCU consultants would work. So when the oncology children come in, they are seen by consultants with a specialist interest in that. The ward round is done by those consultants who feeds back to the consultant of the week and who feeds back to the team. And then also any communication with the tertiary centre can happen by their consultant. And so we implemented a very similar structure for our LTV patients. And we held a monthly clinic where we sort of, using a roundtable format, could meet these patients and their families, chase up any sort of minor referrals for them, make sure we had the most up-to-date care plan, showcase the changes that we had made, and also offer a tour of our inpatient ward and a tour of the hospital in general, so that the patient and their family were familiar with the journey from A&E to ward if this was the first time that they were using our inpatient service. Up of online guidance on how to use the equipment, didactic teaching for both nurses and doctors, multi-professional simulation, and having these on a rotating basis, or rather a rolling basis, should I say, so that all of the rotating staff members would be captured by it. So this is us with a pink star, and all the little blue dots represent our patients, of which we've got 24 patients on some form of longer-term ventilation across 2 boroughs to date. Those 24 patients are under 4 different tertiary centres. They're either under the Brompton, Great Ormond Street, George's, or the Evelina. And there is quite a geographical distance between us and those tertiary centres. And they're tricky to get to, both in terms of public transport and the road network. The other sort of issue, I guess, or road stumbling block that getting to know all our patients through up is that these 24 patients use 5 different machines between them. So that's 5 different bits of kit, settings, troubleshooting, alarms, etc., that we need to get to know here at Woolwich. So just to talk you through some of the patients that we've had through our clinic to date, and some of the changes we've been able to implement as a consequence of holding these clinics. One of our patients with Duchenne muscular dystrophy hardly ever came to Woolwich, didn't attend his routine clinic visits, didn't come here when he was unwell. And we found out really that was because they were worried that his wheelchair wouldn't fit through the door. And so by coming to the clinic and seeing that actually we were holding it in a large, suitable room, his wheelchair would fit through, there was room at the table for both his mother and his carer. Then going to the ward, which they hadn't been back to since he was a young boy, they could see that actually the cubicle that we would always use for patients with on ventilation, again, was more than big enough to accommodate him and his wheelchair and all the equipment he might need. And that really reassured him. What a patient, his mum, fed back to us though, is that actually we didn't have a suitable ceiling hoist to be able to care for him with the dignity that he wanted. And so that was something that we were able to flag up to our management. We'd sort of been highlighting it, but we really needed to get it purchased and get the ball rolling on that. And using the feedback, we were able to. And we can now use that hoist for all of our patients. We can weigh them on it as well. And it just means that we can offer the patients the care they need when they come. We've got a lot of ex-prems on long-term ventilation, as I'm sure a lot of you have, with multiple other health issues. And this particular patient was tracheostomy ventilated. And his parents actually were really keen to come here because it was a bit of a trek for them to get up to their tertiary centre with all the bits of kit that they needed. And they much preferred the visiting policy of our unit here at Woolwich. And so coming to clinic, they were able to meet the team. We were able to explain to them the changes that we had made in both staff education and caring for these patients, which really reassured them. We were able to deal with some referrals that were outstanding and some ophthalmology issues that the patient had. And we took these parents on board as parent champions to help us develop the service and move it forward, which is fantastic. The feedback that we've had so far has been generally positive. The themes have been that parents have really appreciated the streamlining of appointments and getting to know the team and the team getting to know them and their child. They've been able to build trust with us, and there has been recognition that there have been changes in care that we provide at Woolwich following the implementation of this project. They find being at Woolwich often easier, it's closer to home, and particularly our teenage patients like that they could have friends to visit and extended family members, which isn't always the case up at the tertiary centres. Obviously, this was sort of pre-COVID times, unfortunately. And they really found the clinic experience positive, that roundtable format, troubleshooting all the issues in one go, rather than having to attend lots of different visits and lots of different appointments, and just seeing the same faces again and again allowed that trust to be built up. Some of our patients still found the A&E experience a little bit scary and perhaps not as optimal as it could be, and so that's something that we're going to look at moving forward. Before COVID came, we were looking at having satellite clinics and virtual clinics. The satellite clinics, I should say, would be with the tertiary centres coming to us. We've been in discussion with some of the tertiary centres about that, just because it's so much easier for the patient, particularly given we have got quite a large number in our borough. We were looking at holding the clinics virtually or even designing special schools in the areas. And to improve that ED experience, having a linked nurse from ED attend the clinic so that they can get to know the patients and then take back changes to the A&E department. We're continuing to work on maintaining staff competencies with the number of staff rotating as we have that I've already spoken about, and making sure our training package is kept up to date. And in order to oversee all of that, formulating a working group with all the stakeholders. During our COVID time, we moved a lot of our clinics to telephone, and then initially, and then used Attend Anywhere for virtual clinics. And the parents really appreciated that ongoing contact, and actually showed that both telephone and virtual clinics was totally acceptable to patients and their families, and in some cases preferable. So it's definitely something that we're going to look to capitalise on moving forward, because if we don't have to bring these patients into hospital when they're well all of the time, then why should we? We're kind of working on the clinic, having 6 monthly clinic visits, and perhaps one of those would be face-to-face and one of those would be virtual. But it's also good to know that the patients can just pick up the phone if there are issues in between, and we can have ad hoc virtual clinics should we need to troubleshoot any issues. So thank you, that's all I was going to say today.
Thank you very much, Amy and the Lewisham team. So our final presentation today is from Vicky Ward from the Royal Surrey, and it's about support for children and young people with learning disabilities and or autism.
Hello, my name is Vicky Ward. I'm a learning disability nurse specialist for children and young people at the Royal Surrey. The Royal Surrey is a district general hospital based in Guildford. Prior to the creation of my role, it was identified that children and young people with learning disabilities, autism, medical complexities in their families may have had some difficulties accessing the right healthcare and support due to limited reasonable adjustments being in place. Areas such as resources, time, training and awareness were factors for staff. For families, it was around limited care coordination and having to see multiple teams and professionals each time they came to the hospital. And we have a few children on long-term ventilation who access our hospital, and although they can attend rarely, this can increase anxiety for staff around the trust when they are here. My post was created and I started in April 2018. Since I've started, we've been able to implement a number of changes that have hopefully helped improve patient experience, and this includes digital flags to identify patients with learning disabilities, which enables us to have daily reporting so we know if anyone has been into the emergency department in the previous 24 hours, has been admitted, or is due to have an admission or an outpatient appointment in the next 2 weeks. We've also implemented hospital passports, personalised care plans, care coordination and support around the hospital in various areas, including the emergency department and when they're admitted to the ward. We've been working on ensuring that staff and families know about the appropriate equipment and where it is available, including access to hoists, staff training and hands-on support, appropriate transition planning to meet the individual needs, ensuring least restrictive options are implemented, including lots of work around desensitisation for medical interventions, using communication and sensory approaches within the care and support we provide across the trust, and also identifying our most at-risk young people with regards to their healthcare needs, particularly around general anaesthetic and intubation. We've also implemented individualised care plans for going to theatre, and where possible the young person is involved in completing these, as well as individualised work and desensitisation work around blood tests, including communication and sensory approaches and individualised care plans. In 2018, we ran a very successful Hello Hospital event for primary age children with learning disabilities and autism, where they could attend with a parent and carer to find out more about how the hospital works, to explore common medical interventions, to visit familiar areas of the trust that they may go to, including an anaesthetic room, with the aim to try and reduce fear and anxiety for both the young person and their families, so that when they do need to attend, they've all got greater knowledge and awareness about what happens and what they can ask for to help. We weren't able to run the event this year, but we're hoping to run it again next year. Here are a couple of case examples of how some of the changes that we have made have improved the patient experience for young people. This can include coordinating multiple appointments and investigations for the young person. In this particular case, it was around ensuring that everything happened on one day, and we reduced the amount of times that young person needed to be hoisted and the different areas of the trust they needed to go to. We've also been able to improve the patient experience from an acute perspective, ensuring that the voice of the child is still heard, no matter what their needs are, and we reduce the impact of medical trauma. We are keen to make sure that we put patients and their families first, including listening to their past experiences and views on change, providing advice and training for staff, and raising awareness across the trust of the unique needs of this patient group, and embedding a culture of valuing their needs and the reasonable adjustments they require. We welcome feedback from patients and their families, trust staff and professionals within the community to ensure that the changes we're making meet the needs of everyone and ensure a better patient experience. We've seen an increase in successful investigations such as EEGs and blood tests. There's been an increase in more positive experiences of going to theatre and general anaesthesia. And children and young people and their families are feeling more confident to request the reasonable adjustments required and to self-advocate how they would like to be cared for. It's really important for us that we're listening to children and young people and their families about their previous hospital experiences, as this influences how we deliver the care going forward. And with the correct support, children who have previously found the hospital experience difficult have achieved a much better outcome and experience. Personalised care is vital. Listening to children and young people and their families is really important. We ensuring that the right communication and sensory resources are in place. And seeing past just the health issue is important, as families cope day to day with these needs and may not ask for help in the same way as other families do due to their level of resilience. We can be creative around reasonable adjustments. There's no one set list of them, and they should be tailored to the needs of the child and young person and their families to ensure safe, appropriate and accessible healthcare in a timely fashion. Thank you for listening.
Thank you very much, Vicky. So just before we finish up, are there any questions on any of the presentations that we've had today? Okay, well then we'd like to thank all of our presenters today. It's been truly fantastic to hear about all of the amazing work that's happening across our region, and the way in which people are responding to the changes that COVID have presented for us, but also to parent and patient feedback has been really wonderful to hear. And thank you very much to all of our presenters, and thank you all very much for attending as well. If you do want to get in touch about any of the presentations or any of the work that we're doing, then please use the STPN email address. Thank you very much. Have a lovely evening, everyone. Bye-bye.